Good evening.
Good
Chatanji,
evening, sir. Good evening. Good evening.
Chatanji, good evening.
Good evening, Rajendran.
Good evening, madam. Good evening, madam. Sir, Ramesh, sir, good evening. Ramesh Bajania, sir, good evening.
Good evening.
Okay, sir. Good evening.
Sir, I think we'll start, sir.
Chatanji, good evening.
Good evening, Dr. Rajendran.
Rajendran, good evening.
Good
Ramesh,
evening,
good
madam.
evening.
Good evening, everyone. I think we
Sir,
are,
good evening, sir.
pretty much on.
Welcome,
Sure. Boss, good evening. Good evening. Good evening. Sorry,
Good evening, sir.
I think we will start today's ICE program with the pediatrician's prayer. Now I request our treasurer, Dr. Rajkumar, to say the pediatrician's prayer.
Thank you, Thiru. Pediatrician's prayer. Grant us the quality of holistic healing. May we humbly realize how privileged we are in being bestowed with the ability to alleviate suffering. May we be emissaries of help, learning, charity, love, and peace to all children and their families, irrespective of status and creed. Give us the wisdom, understanding to change the things we can, retain the good, and accept within reason the things we cannot change. Grant us your blessings, grace, and mercy in all situations, at all times, and amid all people. Thank you.
Thank you very much. It gives me great pleasure to have the second aliquot of our immunization colloquium by experts. I now request our president, Dr. Rajendran sir, to inaugurate the session. Please.
Thank you, Dr. Respected President 2024, Balashankar, and President-elect Dr. Somasundaram, and Vice President Dr. Gopal Subramaniam, and Secretary Dr. Narmada, Treasurer Dr. Rajkumar, and Academic Coordinator Dr. Thirumurugan, and our Scientific Advisor and South Zone Vice President 2024, Dr. Singaravel sir, and today's resource persons, Dr. Sumita Nayak, and is from Bangalore, and is a well-known person in all over India. And welcome, madam, on behalf of IAPTNSC. And I welcome Dr. Chatan Trivedi. He was my good friend of me, and almost 20 years we are having good relation. And he's a rising star from Gujarat. And I welcome Dr. Chatan. And I welcome today's convener of the program, Dr. Nandini Kumaran, and Dr. Jalil Ahmed is the coordinator. And I welcome all the dignitaries, Joint Secretary Dr. Sudhakar, and Dr. Jayvarna, and Editor Sridevi Narayanan, and AAA Dr. Balaji, and Central EB members, as well as State EB members, other dignitaries on and off the Zoom. And on behalf of IAPTNSC, I welcome one and all. I welcome Dr. Srinivasan sir, well-known academician and professor also from various institutions. And I welcome Dr. Srinivasan sir, and really honored you are here. And
Thank you, sir.
I welcome Dr. Ramesh Bajania sir, and we are so overwhelmed your presence here, sir, and we are really thankful to you be here. And welcome all the delegates, as well as faculties and other students, postgraduate students all over India. And it's a wonderful program coined for our private practitioners, as well as postgraduate also. This immunization ICE program, and it's really it's wonderful program, and it's almost 2,500 viewers last program which was attended, and hope this also will be benefit to our postgraduate as well as and private practitioners. And all the best. Thank you very much.
Thank you, sir. Now I hand over the proceedings of the day to our scientific advisor, Dr. Singaravel sir, to conduct the proceedings and also for the day. Over to Singaravel sir.
Thank you, Thiru, for nice arrangements. Respected President-elect and immediate past President, and our Secretary, and the coordinators of this ICE program, Dr. Nandini, Jalil, and today's experts, Dr. Smita Nayak and Chatan Trivedi, who doesn't need any introduction because they are the stalwarts for vaccine, and our coordinators are properly arranged for the second program. First program went on well, and it is happy that it is graced by our National Vice President of West Zone, Dr. Ramesh Bajania, and ID expert Dr. Rajshekhar is here, and always attended by our stalwart of pediatric youngest student, our Professor Srinivasan sir, and all the dignitaries who are present here and office bearers of State Central EB. This program is going on live, and a lot of people last time they really benefited in the YouTube. It was got a huge success, the first program. Definitely, these two solvers were definitely they make, which is a very common problem which we are coming across. Definitely, it will be very useful. Without wasting much time, before handing over to this, I, with the permission of our president, our West Zone Vice President has joined. Sir, just 2 words from you, sir.
Thank you so much, sir, for this program. I mean, people are looking forward to listen to both of the great academicians, my EB colleague Sumita ma'am and very close friend Dr. Chetan Trivedi. So not to take much time, I wish all the best to the stakeholders for arranging such a wonderful program. And let us hope that we'll continue such type of academic bonanza going forward. All the best and thank you so much, sir.
Thank you, sir. At the end, our Srinivasan sir and Rajshekhar sir will be giving their comments at the end without wasting much time, because our main purpose of this program to focus the science. I hand over to Nandini madam to take over the proceedings along with Dr. Jalil.
Good evening, one and all. It gives me immense pleasure to be here to have the ICE session 2. The first session we have done on the BCG vaccine by Dr. S. Balasubramaniam, and on hepatitis B and polio by Dr. Rajshekhar from Visakhapatnam. And we have the session 2. I'm really thankful to Dr. Sumita Naik from Bengaluru and Dr. Chetan Trivedi from Ahmedabad to have really agreed to spare that time to be with us to educate us and impart knowledge. And today's topic is going to be on DPT vaccine by Dr. Sumita, and on pneumococcal vaccines by Dr. Chetan. I request Dr. Jalil to introduce Dr. Sumita Naik and Dr. Sumita Naik to proceed with her talk. Thank you.
Stop sharing, Dr. Nandini.
No, I'm not sharing anything.
Okay. Can I?
Sir, we can hear you.
Go ahead.
Please proceed,
Start,
sir.
sir. Jalil,
Okay.
you introduce.
Good evening. The most respected President, Dr. Rajendran, and our past Vice President, Dr. Singaravelu, sir, and all the office bearers of IAP TNSC, and the special invitees, Ramesh Bajani, West Zone Vice President, and my colleagues, EB colleagues during 2021, Sumita Madam and Dr. Chetan. Welcome this for IAP TNSC program. And it is my bound duty to introduce my colleague, Dr. Sumita Madam. He is a very well-known, there is no need to introduction because he is well-known across India, and he is a consultant pediatrician in Children's Clinic, Bangalore. His IAP activities are enormous, and he is currently the president of IAP Bangalore 2025. He is the South Zone EB member of PIDA and member of Advisory Committee on Vaccination and Immunization. And we all know the algorithmic rhythm book he has brought out last EB meeting is well appreciated. And he's a national scientific convener for AAPD and national scientific convener for the vaccinology. And we had last year the national action plan in Coimbatore with her leadership. And he's an EB member of Karnataka 21-23 and National Advisory Board member of IAP CAF Journal during 2023 and an EB member AHA Karnataka and Vice President IAP Bangalore Branch 2022 and South Zone Executive Board member of IAP ID Chapter 2022. He's a Secretary of IAP Bangalore Branch during 2019 and 2020. He's a National Scientific Coordinator for ID Connect, and he sees a very vibrant South Zone leader, bringing all the pediatrician in line. So with this, I request our guest, Smita Nayak, to take over the podium. Over to Dr. Smita, madam.
Thank
And
you.
the most prestigious branch of India, that is Bangalore. That is the then president of that branch. Thank you, ma'am.
Thank you. Thank you so much, Dr. Singaravellu sir, Dr. Jalil sir, and Nandini ma'am, for having me on this program. Thank you so much, Dr. Rajendran and the entire team of IAP TNNC for organizing this wonderful session and to have me here. Indeed, I'm indebted to you, and thank you once again for having me here. Please allow me to share my screen. My session today will be on the DPT vaccines, and as this is a vaccine which has been around for a long time. It's a UIP vaccine, so I am going to be dealing with practical aspects more than anything else with regard to this particular group of vaccines. Now, I also have some case scenarios wherein questions will be asked, and I request our audience to kindly put in your yes or no to each question asked in the chat box. Nandini ma'am, it will be,
Yes.
Jalil sir, it will be great if you can just let me know what kind of responses are coming in.
Yes.
And let me go ahead. So I think Dr. Jalil has already introduced me. So let me run through today's agenda. We will be looking at doing the little bit about the vaccines, and then we will move on to talking about what the combinations, as we know there are multiple combinations which are available. So let's look at what combinations are available, and then we will try to think and see whether the correlates of protection are available for this group of vaccines and what they are. If so, what are they? Then we will move on to talk about the Tdap and the TD vaccines, which is also under the same umbrella. And we then take on the cases. So the case scenarios form a large chunk of my presentation for this evening because they will be dealing with all the practical aspects. Also, I will brief you on the catch-up schedule because many a time we get patients who have not taken their vaccines and we are really at a loss to try to understand how to catch up in these patients, and then I will conclude my session. So probably about the next 30 minutes, let's go forth. Now, coming to the vaccine per se, we all know that the DPT group of vaccines are killed vaccines. They contain the diphtheria and tetanus toxoid and the inactivated pertussis. The dose that is used is 0.5 ml. All the preparations is 0.5 ml. It is given as a deep IM injection. It is a freeze-sensitive vaccine, which means adequate temperatures have to be maintained 2 to 8 degrees. Anything falling below 2 degrees, a lot of chances that the vaccine can be damaged. The earliest age for administration of this vaccine is 6 weeks, as we all know, and we have combinations with the whole cell and the acellular pertussis containing vaccines. So we will not really delve in today to the controversy that exists between the whole cell and the acellular vaccines. This has been discussed many, many times. So we look at the combinations that are available. So as you can see here, a whole list which runs from pentavalent, quadrivalent, the whole cell containing vaccines which have based on the numbers, there will be the presence of Hib, Hep B, and IPV. And you also have in the lower part of the screen the acellular pertussis containing vaccines. So there's a whole gamut, there's a whole list of vaccines which is available in combination form, and it's up to each one of us to select what is best. Okay, and what works in your individual practice. So before we move forward, I did mention that this vaccine is given as a deep IM. So can we give this as a subcutaneous? Can it be given in the subcutaneous route? Yes or no? So straight away, I'm asking a question to the audience. So request you to kindly type in on the chat box, is it a yes or a no? Any responses coming in, ma'am?
No, whatever responses, everybody's no.
No, wonderful. So you're not supposed to give the vaccine subcutaneously. So the dictum is the subcutaneous vaccines, which are the subcutaneous preparations of vaccines like MMR, Viralix, etc. By chance, if they go IM, there's no problem. but the intramuscular preparation should never be given subcutaneously. Now, the next question, by chance, if this vaccine, there's an error in calculating the first vaccination date, if it's given earlier than 6 weeks, what are you going to do? Now, before I come to this, sorry about that. Yeah.
Next.
No. And just go back. So if you give the vaccine before 6 weeks, as we all know, the earliest, let it be, the earliest date to give the first dose is 6 weeks. So if you have given it by chance at 30 days, 35 days, or 40 days as well, you need to calculate and call the patient back at the correct time, at the earliest date that they can come back, but at 6 weeks. So not earlier than 6 weeks, the dose to be given.
Yeah.
Now I have put...
The answers are do not consider the dose when given before 6 weeks.
Yes, exactly. Perfectly right. So now the vaccines, this is a little bit about the acellular pertussis containing vaccines. As we understand, there are many, many preparations that we have. There is similarity and some differences in the preparations, but all the brands have been qualified for use. So there is a non-inferiority for all the vaccines. So you can again choose. Now, the last two in the columns here, that's Adacel and the Boostrix, these are the Tdap containing vaccines. As we understand, the T is capital. There is a more of the tetanus portion, that's 20 international units in both the preparations. The diphtheria is equal. The variation is in the pertussis component. However, whichever you use, they are as efficacious. Now, if we look at the Tdap vis-a-vis the first 4 columns, we understand that the quantity of antigen of the tetanus and the diphtheria is much more and therefore it is written as the capital D and capital T, and of course the capital P. Right? So basically that is the reason we use the caps when we write, because there's a difference in the antigenic values. And this is essential because in the age group where we use the Tdap, you are not supposed to give the DTP. If you give it, it becomes much more reactogenic. So that is a scientific basis because of the difference in the antigenic content. Now let's try to understand if there are any correlates of protection for this particular vaccine group. Now, what do we mean by correlates of protection? Well, scientifically, the correlates of protection refer to those antibody levels which provide protection in the body. Now, they are assessed by different tests, including the ELISA test, etc., to find out if at any particular level, which is the cutoff level, above which you can say that the vaccine is protective. Now, unfortunately, with this DTP group of vaccines, there are no standard correlates of protection available. However, for the sake of research and for the sake of studies and for the sake of saying that the vaccine is protective, there are what are known as the surrogate markers of protection. So it means that if the diphtheria levels antibody levels are above 0.1 international unit per ml by ELISA test, that is a surrogate marker of protection. That is, it indicates that your patient has got an adequate response in the body. So the diphtheria and the tetanus is 0.1 ml. For pertussis, unfortunately, there is no known correlate nor a surrogate marker of protection. So please remember, it is essential for us to give the doses as per the immunization schedule, but no definite levels above which we can say that it is protective. So now I move on to the first case. You have a 15-month-old infant who has come with a history of cough and whoop, and this child was diagnosed as well as treated as a culture-positive case of pertussis. Now, the infant has received only 2 doses of primary immunization at 6 weeks and 10 weeks. So please note, there's no further doses given. They have not taken the child back for the immunization. Now, the question is, this child has suffered now for a culture positive pertussis. So do you need to give any more pertussis containing vaccines? So request answers yes or no.
Yes.
Okay, so the answer is yes, you need to give the pertussis containing vaccines. As we understand, as we go forward, I will dwell more upon this, the decline in the antibodies to pertussis with time. And this child, as we understand, is incompletely protected, so has had only 2 doses. Now, what you need to do and what you need to remember is 3 doses of primary vaccinations are definitely required to provide protection. With 3 doses, the known efficacy is 80 to 85%. Please note, with lesser than 3 doses, we really don't know what the efficacy of the vaccine would be. So what you have to do with this child is give 1 dose immediately. So that will be actually completing the primary immunization schedule of 3 doses. So that becomes a 3rd dose. And after a gap of 6 months, you call this child back for the next dose of vaccine, and this acts as a booster. So you do not need to repeat it again at 18 months. You have done it at 15 months and you have covered the child. So as per the ACIP, the WHO guidelines, a child should have received 4 doses of vaccines before the age of 2 years to say that he or she is completely protected against pertussis. So I hope I'm clear on this. So you need to give, in this child who has received only 2 doses and who has suffered from pertussis, you need to complete the schedule, 1 more dose immediately as soon as the child has recovered from the pertussis, and call them back after 6 months. So now I move to the second case, where the child who is 4 years and 2 months has come for the missed first booster dose, which should have been given at 1.5 years. We know 16 to 18 months is the time we give the first booster dose. Now this child is 4 years and 2 months. So what combination are you going to give this child? Will it be a DTP, Hep B, Hib, IPV containing vaccine? Or will it be a DTP, Hep B, Hib containing vaccine? Or just a DPT, Hib? Or a DPT, IPV containing vaccine? Any answers on this? Nandini ma'am?
So far, nobody has answered. They are just,
Okay.
DPT, IPV.
Right.
That's
So
the
please note that this child is a 4-year-old child. So we are talking about the school entry dose. Ideally, it should have been the booster of school entry, but now this child has not had a 1.5-year booster. Never mind, you need to give this child a DPT and IPV containing vaccine. Now, the next question, does she require a second booster at 4 to 6 years? Is it a yes or a no?
Yes.
Okay, so you need, as you understand, at 4 years, this child needs DPT, either a whole cell or an acellular. Also, you need to give the IPV as per ACVIP recommendations. So the ideal is DPT plus IPV, as you noted. All of you have said yes, this is the combination. So if the child has received 4 or more doses of DTP by the 4th birthday, this child is completely protected against pertussis. Hence, once a child crosses 4 years, if you are giving at that point in time a dose, there is no need of giving a booster again at 5 years. So I hope I'm clear. The answer to this question was you don't need to give another dose at 5 years because that will be the 4th dose. If it was anything less than 4 doses, I've already dealt with that in the previous case. Okay, now moving to the third case. An 8-year-old child has come now who has missed the second booster. That's the 4 to 6 years school-going booster. What vaccine will you give? At 8 years, you have missed the second booster. What are you going to give? Also, the second part of the question is, what about the booster at 10 years? Does this child need it? Yes or no? No? Yes? Any answers? Dr. Jalil sir, any answers in the chat?
Yes. Yes, to get the boostrix.
At 10 years. Okay.
10
So
years.
let's see the answer. This child is 8 years old. You are not to give any DTP containing vaccines above the age of 7 years. You have to give a tetanus, diphtheria, and if possible, an acellular pertussis containing vaccine as the dose at 8 years. Now, you have to give a Tdap, that is an adolescent booster, after the age of 10 years. So this child, although you're giving a booster at 8 years, you have to call them back at any time between 10 to 11 years and give them the adolescent booster. Please note, the adolescent booster is absolutely essential because the antibody titers wane with age. Now, the next case, an 11-year-old child has received TD as the 3rd booster. So do you need to give a Tdap? As we understand, in the ACVIP recommends a dose of Tdap. So this child has received a TD. Are you going to give a Tdap, yes or no?
Yes.
If it is yes, when are you going to give it? Okay, so the ACVIP recommends that a pertussis-containing vaccine is absolutely essential at the adolescent age as a booster. So this will give a protection for the adolescent against pertussis. If he or she has received TD, call them back at the earliest. So there's no need for any interval, as we know it's a killed vaccine. Call them back and make sure that the child receives a dose of Tdap. Okay, the next case. An 18-year-old toddler is erroneously given a Tdap instead of DTP. Is it a valid dose, yes or no?
No.
Tdap, as we understand, it is not licensed below the age of 7 years. Hence, this is definitely an invalid dose. If you recall the slide I showed you with the antigen contents of each of the vaccine, we understand that Tdap has a lower dose of tetanus itself and much lower doses of the diphtheria and the pertussis containing the antigens. So therefore, to an 18-month-old, we need to ensure that the child gets a DTP vaccine. So whether it's acellular or whole cell pertussis vaccine, doesn't matter, but you have to rectify the error at the earliest. So as soon as you realize there's an error here, this is an immunization error, make sure you correct it by giving the DTP to this child. The next case, a 15-year-old is brought with a history of fall from the bicycle on the street. Okay, now when you ask, now this child, when you examine, has a deep wound on the right knee, 3 inches by 2 inches, just indicating that it's a deep wound with bleeding. And when you inquire, you find that this child has never received any doses of DPT containing vaccine. So how are you going to manage? First of all, you need to understand that this child definitely needs protection, especially against tetanus. So how are you going to manage? Now, the child is totally unprotected, does require protection against DTP, so you have to start the immunization immediately. This is your opportunity. Besides giving wound treatment, management, etc., you need to start the immunization. And the dosing is a 3-dose schedule. You give the first dose immediately, call him or her back after 4 weeks for the second dose, and 6 months later give the third dose. The option is here, since this is an adolescent, 15-year-old, and we understand that the pertussis is definitely, pertussis component is definitely required, and we only have it in an acellular form. So give the first dose as a Tdap. If they can afford, you can definitely continue the other 2 doses also as Tdap. But if they cannot afford the Tdap, then you at least give the adolescent, a TD dose at 4 weeks later, and again after an interval of 6 months. So the third dose acts as a booster. Will this child also need a tetanus immunoglobulin for immediate protection? Yes or no?
Yes, yes.
Yes.
Yes. So here, this is the schedule for wound management. This is a WHO recommendation. Please note there are different pointers that you need to check out. One is the history of tetanus vaccination, under which you need to inquire about the number of doses and the time, that's the duration since the last dose. And then, of course, you need to look at the type of wound. So once you have these 2 on hand, then you can decide whether he or she requires a vaccine plus an immunoglobulin, or only a vaccine or a booster. So if the child, let's see, a child who has received 3 or more doses of the vaccine, tetanus containing vaccine, which means primary is done and at least a first booster is done. Now, this is a 15-year-old we are talking about. So if it is less than 5 years since the last dose, that means this child has received a dose at 10 or 11 years. And in all cases of wounds, you do not need to give either a vaccine nor an immunoglobulin, right? So if it's less than 5 years. But if it is between 5 to 10 years since the last dose, in case of clean minor wounds, you need not repeat the vaccine. Definitely no need of immunoglobulin. But if it's anything other than a clean minor wound, so it means even if it's a dirty minor wound, you need to give a vaccine. If it's a dirty deep wound or multiple wounds, certainly you need to give a vaccine. But please note, there is no role of immunoglobulin here. Now, if it is a long time, that's over 10 years have elapsed since the last dose of vaccine, in case of all wounds, do not hesitate to repeat 1 dose of a tetanus containing vaccine. Ideally, try to give a Tdap here. And there is definitely no role of an immunoglobulin. Now, if it is uncertain as to how many doses this child or this adolescent has received in the past, or for any reason they tell you that only 2 doses were given, or they say that I gave 2 doses, I'm not sure that the school booster was given, etc. So once they're uncertain about the number of doses, in case of clean minor wounds, you need to give the vaccine, okay? And no role of immunoglobulin. So the role of immunoglobulin comes in only in case of all other wounds. So if it's a dirty minor wound, yes, you need to give immunoglobulin plus vaccine, or if it is multiple wounds, which are like RTA, etc., you need to give the vaccine, and at a different site, make sure that you give the tetanus immunoglobulin. That is available as TetGlob, and this is the dosage 250 to 500 international units, which needs to be given as an IM injection. Okay, now the question that is asked by many of us all the time, is there any difference in protection provided by the wholesale containing vaccines compared to the acellular vaccines? Well, yes, the studies have shown that there is a difference. If you start an immunization series, now please note what I said, if you start, which means the first dose of the immunization, the primary immunization series, if you start it with the wholesale containing, pertussis containing vaccine, the immune response in the body gets skewed towards a Th1 and a Th17 response, which gives a much robust immune response in the body. This is vis-a-vis the acellular pertussis containing vaccine, which gives a more of a Th2 IgG kind of a response, which is not as robust as that which is given by the Th1 and Th17 response in the body. Please note, this, as I mentioned, is if you start the series, that means the first dose, if it is given with the wholesale pertussis containing vaccine, that's when you can expect this kind of a response. If you start with an acellular and then try to give a wholesale, well, that's not going to make much of a difference. Now, what we need to understand is whatever vaccine you give, whether it's a wholesale or the acellular pertussis containing vaccine, definitely there is a waning of immunity over a period of time. However, with the acellular pertussis, it's known to be a little bit faster. So with acellular pertussis, the waning of the antibody titers happens somewhere around between 4 to 5 years. With the wholesale pertussis containing vaccine, it's slightly longer duration that the antibody titers last. So there is a 13% year-on-year reduction in the antibody titers, which are noted after the acellular pertussis containing vaccine. Now, in 2010, there was a large outbreak. In fact, there were a lot of reports coming in from various parts of the globe, especially around the US, etc. Now, that was mainly seen in those who had received the acellular pertussis containing vaccine, vis-a-vis the wholesale. So at that time, as we understand, the US does acellular pertussis only. So that was also attributed to the large number of cases. So this graph actually shows the blue bars are the antibody titers and shows the vaccine effectiveness. So you note that within the first year, there's an extremely excellent effectiveness of the vaccine between 80 to 85% of the vaccine effectiveness is noted. But as the time elapses, you see that there is a waning in the antibody titers. That's the vaccine effectiveness goes down. By 6 years, it's touching around 30%. And as the vaccine effectiveness reduces, the number of cases of disease, of pertussis disease, start rising. Therefore, as we have discussed earlier, it is really essential to ensure that boosters are given by the time the child is at school entry, 5 to 6 years after the last, the toddler booster. You need definitely to administer the boosters at between the 4 to 6 years or 5 to 6 years, whichever time the school entry, you definitely need to administer the boosters. And this is the reason for it. Now, one more case. A child has received Tdap as the 5th year booster. We do know that this is not a valid dose, is it? No, it is not. We have already discussed this. Yeah. So what is the corrective measure now? Are you going to correct this? 5-year-old Tdap has been given. We understand that Tdap is, no, first of all, it's not licensed below 7 years. What are you going to do now? And why is it not a good practice? Well, we know that, repeating myself, it is licensed above the age of 7 years. This is an off-label use, giving it at 5 years. We also know the antigen load is less, and therefore you have to administer a DTaP. We also need to remember that currently, as per ACVIP, we need to give a dose of IPV at school entry. So this child, the corrective measure is to give a combination of DTP with IPV. Right. The most important part of my presentation this evening is this catch-up vaccination schedule. So if there is a missed vaccination or any gap in the series, the dictum is you do not need to restart. So just complete the series. I think we have had enough of cases to talk about that. So please just continue, pick up from where it has stopped and make sure that there is a coverage and age-appropriate vaccination is done. And age-appropriate type of vaccine is also selected. Below 7 years of age, you can use the wholesale or the acellular containing capital DTP vaccination at 0, 1, 2, and 6 months after the last dose. So depending on how many doses are missed, please count that and make sure that these are the number 4 doses which have to be given. If the last dose is given beyond the age of 4 years, a second booster, that is after 5 years, is really not required. Above the age of 7 years, you need to do the Tdap, 0 dose. You can give a TD at 1 month and 6 months and follow by TD every 10 years. You can also use TDAP, that's Tdap, because there is data on the safety as well as efficacy. And if you have 3 doses given above, the third dose, if it's given above the age of 9 years, there is no need to give an adolescent booster dose. So please remember that. Crossing 9 years and you're trying to complete an immunization schedule, there's no need to give another dose in the 10th year or the 11th year. Between the ages of 11 to 18 years, the Tdap has to be given, followed by Tdap or TD every 10 years. So this is the most important part of my presentation, which is the catch-up schedule. Oftentimes, we have a lot of cases which come in and we are in a doubt and a quandary as to what to do. So please note, you can take a screenshot of this or take a pic of this, and this is what you need to keep with you to ensure. Now, I still have one more case. There's a child who has developed a single short-lasting afebrile seizure after the second whole cell pertussis containing combination vaccine given at the age of 10 weeks. Is this a contraindication for the use of the whole cell containing pertussis for the third dose? Now, please note, earlier days, yes, it was considered as a contraindication, the occurrence of seizures, but these are now, there are a whole bunch of precautions and these are not contraindications. So what are they? The history of fever, high-grade fever, history of afebrile seizures, HHE, excessive crying for more than 3 hours. So these are precautions, which means there's no contraindication to the use of the whole cell pertussis vaccine, but you have to take care and probably, have the child in a setting where you can administer immediate measures, institute immediate measures if there is any seizure or any untoward incident. Now, the role of encephalopathy following DPT, as we mentioned, it's not a contraindication, but it is a precaution. And it has been found that it is not per se due to the vaccine, but it is due to something called as the Dravet syndrome, which is basically a sodium neuronal channel encephalopathy. So there's a deficiency of the sodium neuronal channels in the child, and therefore they throw the afebrile seizures. So there's the causality of DPT for the encephalopathy is not proven. So the only absolute contraindication for DPT is a severe allergy to a previous dose, that is any anaphylaxis which has occurred. That, dear friends, is the only contraindication for giving the DPT vaccine. Now we know that pertussis infection can occur in the newborns, and if it does, it's very severe. It could be even life-threatening. Very high morbidity and mortality in the first 6 months of life. So how are you going to protect the newborn from pertussis infection? We know that we are going to be giving the first dose only at 6 weeks. So what you need to do is we need to ensure that we spread the information of giving Tdap in every pregnancy, irrespective of the interval between pregnancies. This information has to trickle down to all our obstetrician friends, and we have to ensure that they do give the Tdap, not just a TD. Between 27 to 36 weeks of pregnancy, because this is the time when the maximal transplacental transfer of the immunoglobulin happens and it is of benefit to the infant. So please note, we are giving Tdap to the mother for protection against pertussis in the infant, and of course, for protection against tetanus in both of them. So this is the best way of protecting the newborns, right? Now, also the strategy of cocooning, which is really not very much enforced these days. So we need to give a dose of Tdap to all senior citizens in the house, and all the other children in the house should have the DTP vaccine up to date. So this will definitely help to reduce the risk of infection. Now, these are all the various brands, like I said at the start of my presentation, the whole gamut of presentations of the vaccines which are available. There is nothing which is inferior or superior to any of the other product. Please feel free to select whichever you want. These are the vaccines. The upper two are the Tdap vaccines which are available, and of course Serum Institute which has the TD vaccine. So we have a whole lot of offerings in the basket. It's a very big basket, very open basket, and you can select anything that you want from it. So before I close, the conclusions that we understand that DTP is definitely an essential childhood vaccine. Whole basket of presentations, lots of combinations available. Please select. Please make sure that you take the age-appropriate vaccine and administer it, and the titers decrease with time. Hence, booster doses are really, really essential. And the benefits of giving the combination vaccine, as we all know, definitely there's much, much, much better patient compliance, and the number of physician contacts is definitely reduced. Thank you so much for your patient hearing. And if there are any other questions, well, I would take them. Thank you.
Thank you, madam. That was an excellent presentation.
Wonderful presentation.
And this shows the madam has completed the advanced vaccinology course in Vellore. I still remember in 2023. And this course also continuing in our ICP also. Madam is one of the core faculty there. Dr. Nandini, is there any?
I would just, there are lots of appreciations that there is a very nice presentation, very common for pediatricians in practice. And one question is, how will you give DPT vaccine for a hemophilic patient?
Well, that's a great question. Yes, you have to make sure that you choose the first thing is make sure you choose the narrowest gauge possible, and the size, the length is important. Like I mentioned, it has to go deep IM. So based on the muscle mass, make sure that muscle mass of the child, make sure you select the correct needle length as well as the needle diameter. The second point is time it at such a time as you give it immediately after the child has received the replacement factor. So as close to the replacement factor, call them back for the vaccine. And the third point to remember is do not rub after giving the vaccine. Just apply deep pressure, and that will stop the bleeding. So these are the 3 points that you need to keep in mind while immunizing a hemophilic child.
If we know the patient well is a hemophilic, it's better you can ask for the level also. The facilities are available.
Yes.
In every lab they are doing the factor level. Then you can
be on the safer side. Ideally call them back as soon as they've taken the factor, replacement factor. So in a day or two, it's ideal time to give the vaccine.
There's one other question, madam. Tdap is not available in government setup. So how will you proceed further? Because then the adolescents will be getting only the tetanus and the diphtheria. In fact, earlier it was only tetanus toxoid. Now at least they are giving tetanus and diphtheria after the resurgence of diphtheria in many parts of India, especially in Kerala and in South India. So, but under the government policy changes, we have no...
Yes, yes, ma'am. So yes, that is definitely, it's a practical problem that is a lot of us face, especially those in the government sector. So I think the only answer to that is to ask them if they're able to afford to take it in the private setup, because this is whatever we have discussed is as per the ACVIP recommendations and not the UIP. So if they are willing to go out and spend a little bit more to have their adolescent protected, so be it. If not, at least a TD, that's it. I mean, there's no other way out currently. We do hope that in the years ahead, Tdap will be made available in the government sector.
I think there's another question. When to give the DPT vaccine after a child has diphtheria infection? I think earlier, madam had discussed a case scenario of a pertussis. We have to remember both diphtheria, pertussis, tetanus. None of them after a natural infection gives a lifelong immunity. So all these diseases require a vaccine after the child recovers from the disease. And
As
the
soon as the child is stable, I think that would be the answer. As soon as the child is stable, you need to ensure that the immunization schedule is completed.
now, will the giving the anti-diphtheritic sera, will it interfere? Is there any specific time schedule because you have used the sera for immediate protection and the treatment? So should we wait for some time? What is the ideal time to go about?
Well, this is a killed vaccine, so there's really not much of an interference there. So whenever you find that the child is has recovered and is stable, I think you have to get them back and ensure that the immunization schedule is completed.
Some of them are requesting, can you show the slide of the catch-up vaccination schedule? I think they missed the screenshot.
Can I share?
Available in YouTube.
Yeah, please.
And madam, one more question from my side. Is there any, there's a product switching in case
Yes,
of triple antigen or DPT, product switching? What do you suggest?
Ideally, you're supposed to use the same brand, but for any reason, if you are not able to get the same brand, for any reason, if you're not able to get the same brand, then you can use any brand that is available. The idea is to ensure that the child does receive the dose of vaccine and does not go unimmunized.
Dr. Geeta Patel has asked, what is the length of the needle and the size?
We acknowledge the presence of Geeta Patel, madam. Welcome, madam.
Yeah.
Sir, SBS sir is also there.
Yeah.
Good evening, sir. SBS sir and Geeta Patel, madam. Madam wanted to know what will be the ideal size.
Well, you have to look at this, the muscle mass. As I mentioned earlier, you need to look at the muscle mass, and based on that, you have to select the size. So for the infants, you will take probably a 1 inch, and when the smaller children, you'll take the 1.5 inch, the older than the infants. So somehow I'm not able to share. 1 minute, I think I have closed my slide. So.
And can be changed from whole cell to acellular or vice versa?
You can change. I mean, there is absolutely no contraindication to change. So you can change. Like I said, based on whatever the vaccine, ideally you're supposed to give whatever is, the vaccine, the same vaccine type as well as brand. But for any reason, if it is not there, then you can change it. I'm just trying to get the slide on.
I think it's before that.
Before, yes.
Before the pregnancy and the, yeah, this maybe after this.
Yes, here it is.
Yes.
Here it is.
Yeah.
Thank you.
All those have missed can take the screenshot.
Yeah, please.
And one other question, madam, because many times, at least a year or two back, people used to use the Tdap for the second booster. And you have really clearly showed us how it is not the ideal one because it has got lower antigen levels and it will not be the ideal one to be used. And only thing.
May I stop sharing the screen, ma'am?
Yes, ma'am. Yes. And Tdap in one of the inserts, pocket inserts, PIs, says can be used from 4 years. I think I'm sure you know the company. We're not supposed to name the company. The PI says you can use it from 4 years, but that is not the idea, as madam has clearly explained. And moreover, we want also IPV because of the waning immunity. So the school entry booster should always be DTWP or DTAP plus IPV.
Ma'am, actually, this question is really valid because at one point in time, we were not getting the DTP IPV containing combination. So at that point in time, yes, Tdap was used. A lot of practitioners have used Tdap for lack of any other better product available. And as you rightly mentioned, yes, the PI does contain that the information that it is valid for above 4 years. Definitely true. But currently, we do have the DTP IPV containing combination, and therefore, I think currently we should not be using the Tdap. If you have noticed erroneously done it, given it, please correct it and give the DTP IPV containing combination.
Thank you, ma'am. Further questions can be taken further after the second session.
Yes.
Here we acknowledge the presence of Dr. SBS and many persons from other states have joined for today's program. We welcome all on behalf of our scientific team.
Good
Over
evening,
to-
Bala sir. Thank you.
Thank
Hi.
Hello,
Yes.
Bala sir. Vanakkam.
Please go ahead. Please go ahead.
Sir, thank you, madam, for this lucid. Good evening, sir. Thank you, madam, for this lucid talk on DPT vaccines with your presentation and the various case scenarios you've discussed. You have made it very clear that the primary doses are essential and this should be followed by the boosters. And decennial or DT every TDAP or DT every 10 years is also very essential. The decennial boosters after 10 years is very, very essential for the smooth maintenance of the immunity and to decrease the incidence of the disease in the pediatric population as well as in the adults also. So now we go to the second session of the ICE session number 2. This is going to be on pneumococcal vaccine, and we have none other than Dr. Chetan Trivedi from Ahmedabad and Dr. It is it's a pleasure to introduce Dr. Chetan Trivedi. He's a consultant pediatrician and neonatologist, and he is also an infectious disease consultant. And he was formerly the president of the AOP Gujarat in 2023, organizing secretary for IPA Pedicon 2023, executive board member of the Central IAP in 2016 and 21, scientific convener. We usually have the Ahmedabad Connect and the Wednesday Wisdom, and he's been the secretary of the IAP ID chapter and the past president of AOP Ahmedabad in 2013 to 14 and subsequently also, and a very knowledgeable person. And we have him today to discuss on the pneumococcal vaccine. And over to you, sir.
Yeah. Good evening. Am I audible?
Yes, sir. Yes, sir.
Okay. So first of all, I extend a warm thanks to all my dear friends at Tamil Nadu, starting from Dr. Rajendran, good friend of mine, Dr. Singhavelu sir, Dr. Jalil, Dr. Nandini, and teacher par excellence. The presence of them really encouraging Dr. Bala sir and Dr. Srinivasan sir and Dr. Terumurgan. I think many of the friends have been seen on the screen. So I'm not taking name, but really I'm very happy to be here on this platform with all of you. So it is always, after you see, that Dr. Sumita gave a very wonderful talk, and that too a very practical talk, and about a very common vaccine. And now I have a difficult task of talking on the pneumococcal vaccine. Why difficult? Because it is one of the most dynamic vaccines. Because you know that if we have presented this just 3 months before, we have to change a lot many things in the next presentation. That's what dynamicity about this particular vaccines. And my presentation will be a slightly different than what Dr. Sumita discussed, because mine will be, I think when you listen to it initially, maybe I'll be 20-25 minutes, I'll be just narrating a fiction sort of thing. So after that, you will all be, encouraged to ask for the practical questions, and that's what I expect, because I'm not taking case scenarios, but I'm just giving you a fiction story of this pneumococcal vaccine. So how I have flowed my flow of discussion is, what first I'll try to give you understanding of what is the culprit bug, what is the spectrum rate, why do we need pneumococcal vaccine, what is the data of the serotype prevalence in India, it is very important. What is the history and developmental path of different pneumococcal vaccines globally as well as in India? What are the spectrum of PCVs, pneumococcal conjugate vaccines available in present and future? What are the serotype coverage of available PCV in India? Schedule particularly for high-risk conditions, and adult immunization I'll be touching upon, because that's also so much of change is happening. And lastly, we'll be having a question and answer session. I would request Dr. Nandini and Dr. Jalil to moderate. So the culprit, yes, it is Streptococcus pneumoniae. We know it's a gram-positive cocci, diplococci. Now, what is more important is the polysaccharide capsule of it. Now, this is a virulence factor, and that's why everybody's eye, all vaccine manufacturers' eye is on this particular capsule, because it defines the serotypes. All the serotypes have been defined by this particular capsule. That's why it's a vaccine target. Now, when you talk about serotype, there may be more than 90 to 100 serotypes of this PC, pneumococcus, Streptococcus pneumoniae. Now, all are different. different in terms of maybe a toxicity or antibiotic resistance. They are not equally pathogenic. And if you see about 27 serotypes, they account for almost 90% of the most frequent isolate. And out of this, if you take 7 to 11 serotypes, that will be almost 70 to 80% of pediatric infection will be by this particular serotypes. That's why majority of us, they try to cover the common serotypes. Now, what is the disease which is called by pneumococci? Now, why I'm giving this? This is a simple thing. We know that pneumococci strain, they have been there in the nasopharynx. So nasopharyngeal carrier is very important because it is the site from where your bugs are going to enter. It may go directly to either cause ear and otitis media. It can go to meninges and cause meningitis. It can go directly to lungs and cause pneumonia, or it can go to sinus, cause sinusitis. These are the direct illness. Now, once it enters in the blood, it causes a bacteremia. And after that, whatever is happening is the invasive pneumococcal disease. And that's why when you talk about the invasive pneumococcal disease, it is usually through blood. So when you have these particular bugs in the throat, you're going to excrete it. The aerosol or a droplet transmission is going to occur. Now, this is important. You may have pneumococcal carriage or you can have a pneumococcal disease. It can be invasive or mucosal. Now, we are not talking much about mucosal. Why? Because whatever mortality is occurring, it is more because of the invasive pneumococcal disease. And pneumonia is part of both. It can be direct as well as through the blood, it can spread. Now, when you see the spectrum of disease, we have the very small part of invasive pneumococcal disease. But it is very important because it is creating a morbidity and mortality. Now, what is the significance of nasopharyngeal carriages? Because if you have that bug in your throat, it is going to cause the disease. It is going to spread. And we know that it is having a nasopharyngeal rate in our country. It is on a higher side. In general, globally, it is 27% to 85% of the people, their children particularly, they are having a nasopharyngeal carriage. So that's very important. Now, why do we need pneumococcal vaccine? Because one, what is the disease burden? It's a high prevalence disease. Because you know that streptococcal pneumonia is a leading cause of the vaccine preventable pneumonias. And when you talk about morbidity and mortality, it is one of the maximum mortality causing bug. And that's why we have to take care of this particular bug. We have a vulnerable population. Two, one is less than 5 years and another is the extremes of the age, more than 65 or this, the elderly people. Now we have the antibiotic resistance. We know that now we have found that there is a resistance to penicillins also, and that particular resistance can be transferred to the cephalosporin groups also. Now, after all these risk factors, we have availability of the safe and effective vaccine, and that's why we need that vaccines in our schedule. Now, which are the serotypes? Because whenever we talk about the country-specific thing, we have to understand which are the serotypes which are common in India. So, when we talk about this data, there are n number of studies are available. Maybe almost 120 studies are available. So you can't go into detail of this, but these are the main major seven studies. But look at it. Suppose Vanna et al., that's a PDOP study. There it is all are prospective studies. It can be a hospital-based study. What can be the difference? Few studies have been done over more number of states. Few studies are done at a particular one state, one center. Few studies have been, different in the number of the positive cultures, maybe looking at 5,564 to 51. So there are different number of isolates. Also, if you see the diagnostic methods, that can be culture as well as PCR, the both, and the serotyping method. So there is wild variation of this particular studies. So what can you take from this? No, there is Josna et al., the review article. What she has considered is all these seven major studies, and they put it in a one block. And there you can see these are the vaccine serotypes. This is done in 2017, so it is taking care of PCV13. So these are the strains, serotypes which have been present in the existing vaccine, that is PCV13 present at that particular time. So that is about serotypes which is distributed in the India. Now, what is the historical perspective? We know that historically, we know that the South African gold mine workers, they were given some, indirect protection by getting a raw infection. So what they found that they may be a non-serotype specific heat labile vaccine that can be given, and that worked very nicely initially. So after the discovery of this pneumococcus in 1881, there was a period when there was a wholesale vaccine which was given. But then what happened? Then the invention or the entry of the penicillin came into market. And people were so happy that now we have the solution. Why do we need vaccines? So for 25 years, nobody thought of it that. But then Robert Ostrich, the person who did, he showed that there is going to be deaths because of the antibiotic resistance, because of the penicillin resistance within 96 hours. So even if we have penicillin, still you can have deaths of the people. And that's why he was able to convince the people we need a vaccine. So initially in 1977, they had 14-valent polysaccharide vaccine. By that time, people, they understood that there are different serotypes. So they started using 14, and then 1983 was the first time when there was a launch of 23 capsular polysaccharide. That is PPSU 23, still it is coming. It's available. So 1983 is very important because we won the World Cup under the leadership of Kapil Dev and this launch of 23 capsular polysaccharide vaccine. Now, this particular vaccine was very good, but there was a problem because it cannot be given less than 2 years of age because it was polysaccharide vaccine. And we know that the basic maximum burden is in younger age group. So we wanted to have the option. What was the option? At that time, there was nice, use of conjugation technology. In very successfully, it was done with the HIV vaccine. And looking at that experience, they transport that polysaccharide to the conjugate vaccine. Now, why this conjugation was required and what was the advantage of it? There was biggest advantage. One is it became T cell dependent. That's why it could have been given less than 2 years. That's earlier it can be given. So there where the vaccine is required the most. Yes, it was having a higher immunogenicity, immune memory came into picture, and boostability. We know that polysaccharide vaccine, if you keep on giving it, there can be hyporesponsiveness. While this conjugated vaccine will have a boostability. It provides a hard effect. It is important. If you vaccinate one person and if you get the two more people getting protection against this vaccine or disease, it is good. It is a herd immunity that has been available with this conjugate vaccine. It reduces the nasopharyngeal carriage, and that's why it prevents the spread of this particular disease, and it helps to contain the antibiotic resistance. Yes, these are the advantages of conjugated vaccine. That's why we shifted from polysaccharide to the PCV. There was a launch of PCV7. It was 7 serotypes clubbed together in USA. It was such a wonderful vaccine because it was the only vaccine which is available with double-blind randomized controlled trial of efficacy. It was so effective that people were convinced beyond doubt that there was no need for further efficacy trials. So that vaccine worked very nicely. It reduces the invasive pneumococcal disease because of serotypes which were there in that particular vaccine in the tunes of all 97% reduction. Almost 45 to 46% reduction in the pneumonias caused by this particular serotypes. So it was all good. But then what happened? We know that these serotypes are not enough. What they found, once they introduced the PCV, there were decrease in the incidence or the prevalence of this vaccine serotype. But there were few serotypes which were not covered by vaccine that started coming up, particularly 19A. So because this was a US centric vaccine, so they wanted to expand the horizon to all over the world, and that's why they thought of adding the serotypes. And what happened? With that first advent of the 2009, there was a launch of PCV10 that was in Europe, that was GSK. In between, there was a trial done by PCV9 and PCV11, but ultimately it was PCV11 which was converted to PCV10, that was of GSK. At the same time, maybe in a year, the PCV7, which was by the Pfizer brand, that was again, it increased the serotype to 13, that was Prevnar 13 was launched in US market. Now, with these two serotypes, what happened? It was working wonderfully. But again, there was something called serotype replacement. So they got the better effect of this vaccine serotype. But what happened? When the vaccine serotype, they went down, at the same time, those who were not vaccine serotype, they started coming up. So what happened? You see, 2010-11, 10 and 13 valent vaccine came. They replaced 7 valent. And what happened? They reduced the burden of invasive pneumococcal disease because of vaccine serotype. But then ultimately non-vaccine serotype, they started rising. So the benefit was not seen properly. And that's why now we are increasing the number of the serotypes. And that's why now from PCV7 to 10 to 13, and we know that now it is going to almost to 21. So then what happened in 2021? We got a PCV15, PCV20 license. This I'm talking about globally. Okay. And 2022, there was PCV15 by MSD. 2023, PCV20, which was launched in 2021. It was for adults. Now it is available for children in US also. And latest, it is PCV21 MSD, which has been launched for the adults in USA. So this is all the historical and developmental path of pneumococcal vaccine. So it is a very fascinating journey altogether. Now, what is in India? These all vaccine came into Indian market. PCV7 in 2006, then 10, there was PCV13. At the same time, it was GSK's PCV10 came. Then Indian brand that came. That was PCV10 by Serum Institute that came just, I think, around in before the COVID, and that was PCV10 by Serum Institute. Then 2023, we got PCV14. So that again increment in value around PCV13, missing out some few serotypes and adding few. In 2024, this PCV14 again now the Abbott is coming to picture. They are marketing the same vaccine. And now latest in 2025, we have one more new entrant in this particular segment, that is PCV13. Here it is by GC Chemi and DRL. Together, this particular brand is having a different conjugate protein. So now let us try to understand the spectrum of PCV present and the future. What all are the vaccines which are available? So if you see, you start from PCV7, these were 7 serotypes. Then GSK, there were 3 serotypes more were added, 1, 5, and 7F. Then came PCV13 of Pfizer. They had all plus these 3, 6A and 19A. We know that 6A and 90A are very important, and that's why that was included looking at the experience of previous vaccine. Then PCV10 of Serum, that missed out on 4, 18C and 3, and they added 6A and 19A. So that was the difference. So it was PCV10. Now PCV14 from B that has come. What they have done? They have missed out on 6A. Okay. And they have added 22F and 33F. So this is what we have at present. Maybe in future, rather it is available in the world, PCV15 of MSD. What is it? It is just PCV13 plus 22F and 33F. So it's also having 6A. That's a wonderful thing. So this is, you club this both together, it is PCV15. And also there is Tergin Arabindo is also there. But there are other 2 strains are different than 22F and 33F. PCV20 of Pfizer is having, again, there are more incremental value of this particular serotypes. Okay, so are these all PCV same? No, because there are number and types of serotypes are different. There's a conjugation protein as well as technique is different, and the composition is different. How? Let us see. This particular, suppose you see the serotype difference you've already seen. But see, GSK brand is having a different conjugation protein. Okay, here PCV10 of Serum, PCV13 and PCV14, they have CRM 197. While one more addition, that is PCV13, it is just same as Pfizer's brand, that is Prevena 13, but they have different conjugation protein, that is TT. Then another difference is, if you see this antigenic content of PCV13 here, it is different here, PCV13, antigenic content is different. So you can't say 2 vaccines are going to be the same. Of course, because of there is a patent issue as well as so many other things they are to be considered. That's why all these PCVs are different. Okay. Now, how the new vaccine they get approval? WHO says that you have to show that the new vaccine is having immunoglobulin IgG for all common serotypes collectively more than 0.35 microgram per ml. That is the serocorrelate of protection. You have to have above that. Okay. Now, this is collectively, it is not individually. Now, suppose DCGI, the new vaccine comes into market. We know that after PCV7, there is no more randomized double-blind control trial of efficacy is required. So what you need to do, just you have to prove the non-inferiority to the existing. So suppose you have the vaccine, because PCV7 was there, then PCV10 was introduced. They showed non-inferiority to PCV7. PCV13 also showed the non-inferiority to PCV7. Whatever vaccine, suppose PCV10, when it entered into the market, there were two vaccines in India which were given, 10 and 13, right? So they were compared and was proved non-inferiority to existing brand. So this is as simple as that. You have to show that there are definite non-inferiority criteria that has to be fulfilled. Now let us see all these 4 available brands. What is the estimated coverage, serotype coverage? So if you see, there is some difference here and there depending upon different studies. So overall, if you see, there is the difference of maybe around 15 to 20% in serotype coverage, which is existing in our country. I don't know how far it is significant. Definitely, it is considered for all this vaccine talks, or particularly pharma-driven talk or vaccine company-driven talk. But this is a basic, unbiased coverage of serotypes. Now, what are the schedule? Now, this is a colorful thing, but we have to understand all vaccines are not same. They have different sort of the schedule which has been approved by DCGI or ACVIP. So when you see this particular PCV13, we know that 6 months onward it can start. You have to give 3 doses, 6, 10, and 14, and then you go for the 1 dose in second year of life. If you start around 7 to 11 months, you need 2 doses at a week interval and second year booster. 12 to 23 months, you have to give 2 doses at interval of 8 weeks, and then you are done. So after 2 years, only vaccine which can be given is one is GSK 10 valent and PCV13. PCV13 single dose is required, while PCV10 is GSK 2 doses required at 8 weeks interval. Now look at this PCV10 of serum. They have approval for the primary doses, but not for booster dose. But they have been given ACVIP green signal for this booster because WHO has given the approval for booster dose of second year. You look at PCV14, only it is approved for first primary immunization series, that's 6, 10, and 14, 3 dose. There is no recommendation whatsoever for second year. Similarly, the new entrant, that PCV13 TT, DCGI approved, ACVIP has not been data has been submitted to ACVIP. DCGI approved is 3 doses, 6, 10, and 14, no recommendation for the booster dose. So this is in a nutshell whatever vaccines available, different vaccine schedule. Now, what is the role in high risk group? Now, here we have to understand there are different high risk group. One is the high risk which is immunocompetent, but they are high risk, like CHD, chronic lung disease, liver disease, alcoholism, this thing, or chronic kidney disease. Here we have to give PCV13 plus PPSV23 1 dose because they are immunocompetent, but they are high risk. Now, there is a group where they are immunocompromised, like the most common is anatomical or functional asthenia, sickle cell disease, congenital or acquired immunodeficiency, HIV. These are the conditions. Along with that, there is one other group which is immunocompetent, but with CSF leak or cochlear implant. This brings into the very high risk. So here what you require is PCV13 plus PPSV23 in 2 doses. So you give PCV13, then after 8 weeks you give PPSV23, and then after 1 year you have to give the second dose. And if it is not much immunocompetent, you can give it at 5 years apart. Now this is the schedule, but we don't want to go into details of it. What we should be understanding is, if the patient is in a high risk situation, you may have to give 1 or 2 doses of PCV13 followed by 1 or 2 doses of PPSV23, depending upon the age as well as the history of previous doses given. Okay. Now, when we are giving 2 vaccines together, like PPSV23 as well as PPV13, which will you give first? We will give the PCV13 first, followed by PPSV23. Why? There is a reason behind it. Because evidence they show that initial single dose of PCV13, it amplifies the anti-pneumococcal response of subsequent administration of polysaccharide vaccine for many common serotypes. And if it is other way around, if you have given PPSV23, if you give it within 1 year of PCV13, because we know that 23 different antigens are there, your system has been flooded with that, so PCV13 will underperform. And that's why always when you are giving together, both is indicated, first PCV 13 and then PPSV 23. Now, adult immunization, one word about it. Now, there is so much is happening. Adult immunization, how early, which PCV and schedule. Now, if you see, follow from 2015 onwards, there was this recommendation that more than 65 years or those from 19 years onwards, but immunocompromised, you have to give PCV 13 as well as PPSV 23, depending upon whether they have received previously PCV 13 or not. But now, with the advent of new vaccines, which is available in the global market, what are they? Of course, this is PPSV 23 is there, PCV 20, PCV 15, and PCV 21. Now, there's a huge lot of difference. If you can see this PCV 21, you should look at it. There is a big difference between 10 and 21. So 20 is containing these vaccines. Okay. And most important is particular 4, which is missed out in 21, and PCV 20, they is having a 4. Now, looking at this, there is a change in recommendation for PCV for adults. Suppose if you have age group more than 65, or you have 1965 immunocompromised, or same age group with CSF leak and Colloquium implant, you have to go for PCV 20 or 21. You should not go for PCV 13 or PPSV 23. So actually, practically, PCV 20 or 21 replaces PPSV 23. And yes, gap between these two should be 1 year between PCV 13 and PCV 20 or 21. While if you want to give PPSV 23 after PCV 13, it should be 8 weeks. So this is in general. But now, look at this. CDC website is being modified to comply with President Trump's executive orders. So look at this. This is Morbidity and Mortality Weekly Report, January 9th, 2025. What they have seen, they have shown that what was we were knowing before October 2024. Single dose of 15 valent, 21 or 20 valent pneumococcal vaccination vaccine was recommended for adult aged 19 to 16, 4 years in a high risk condition, and all above 65. But now what has changed is they say it has to be given all above 50 years of age. This is the new recommendation which is now implementation since January. So this is the latest. So after the entry of Trump, age has been lowered. Now what is happening in India? India, we don't have a specific recommendation, but we know that what we have available is only PCV 13, which is recommended above 50 years of age. Yes, we can give it at 50 years of age. And that was, there are many guidelines, but first guideline which we following was something like this, the Indian Vaccine Advisory Guidelines. They said it has to be given above 50 years of age, right? But now then there was a discussion and another group came. They said, no, 50 years, it is too early to start. We should not be vaccinating. We should be giving at 65 years and more. And there is one more Parvez Kaul et al. Group. They have said that post-COVID, the risk is becoming increasing. And that's why we should be lowering it to 60 years. But as of now, no standard guidelines for the vaccination of adults of PCV in India. But what we can say is above 50, definitely you can give. And particularly if you have some risk factors above 50, definitely you will be giving it. Yes, PCV 13 is the only vaccine which is available in country to be given for all age group. As such, it has been allowed to be given for first 5 years. That is fine. For 6 to 18 years also, it can be given. 18 to 50 years, that in high risk, and above 50 years. So PCV 13 is the only vaccine which can be given in all age groups. Now, what is beyond vaccination? See, we know that PCV, when you want to prevent pneumococcal disease prevention or pneumonia present, so you have to have a vaccine. But of course, at the same time, case management appropriately done, nutrition, particularly breastfeeding exclusive for first 6 months, balance that, reducing risk factors. This is another important factor. Indoor air pollution and tobacco smoke, as well as crowding to be avoided. Then we can definitely take care of this pneumococcal disease burden. So now I think this is in brief. I just shared my presentation in view of our pneumococcal vaccines, and I think its questions from moderator and delegates are welcome.
Thank you.
Thank you so
Dr. Chetan. I think it was a very good and a very smooth way, and you had forth a difficult pneumococcal vaccine, the travel history and what changes have happened to almost the latest update of the January 2025 report also. That was a very smooth journey about the pneumococcal vaccine. We will just look into the chat box, but before that, I just thought, can you just let us know, pneumococcal vaccine is being given in the private sector as per the ACVIP or the IAP guidelines, as well as now it is also being used in the NIP, the National Immunization Program in the government. Is there any difference between the schedules, and if so, what is it?
Yes, now we know that National Immunization Schedule, they follow 2+1 schedule of pneumococcal conjugate vaccine, PCV. Now, NIP, they are giving 6 weeks, 14 weeks, and 9 months booster, right? So, and in private sector or ACVIP recommends for individual protection 3+1. So it is 6, 10, and 14 weeks primary series, followed by booster in the second year. That is what we have been advising. Now, why this difference? Because the South Africa, there was a brilliant study by Dr. Shabib Wadi et al. What they found that initially the thought came that there was, accidentally it was given one dose, incomplete schedule. What they found that incomplete schedule also was giving some protection. But when you give it 2+1 schedule, it was almost 100% seroconversion. So looking at that, and because the government would like to look at the number of the people need to be vaccinated, and we have a big cohort, maybe 26 million people, kids are there. So they would try to look at the cost as well as reducing number of doses. At the same time, if we have data which is showing that seroconversion is almost in terms of 100%, I think 2+1 schedule is good as far as the national immunization schedule is concerned. But individually, because we know that if you give 6 and 14 weeks primary series, and then you give it at 9 months, this is what variant of 2+1 series, or we can say 3+0 schedule. So in that, you miss out on two strains. They are underperforming less than, more than 10%, like 6B and 23F, between the primary series and the booster, which is given at 9 months, right? And secondly, we need a certain coverage, particularly for serotype 1 and 3 in second year. So that's why we would like to have one more dose in second year. If not, latest before 1 year, like we should have one booster dose, and that's the concept. So government national immunization scheduling is trying to balance everything, but for private practicing pediatrician or an ACVIP recommendation is 3+1, where first 3 doses to be given 6 months, 10 and 14, and second year booster to be given.
Thank you, doctor, for that lucid fact that was brought to think. Dr. Jalil.
Yeah, that was an excellent presentation, Chetanji. Very good information, you got it. Let us start with some kind of a clinical scenario. Sir, there is one 14 weeks old infant brought for third dose of vaccination with the pre-birth dose and 6 and 10 weeks vaccination in the NIP program. In this scenario, how will you plan for further vaccination? How many doses of PCV you have to offer?
So can you I'll just repeat it. It's a 14 weeks infant, right? So
yes, he has for the third vaccination.
Okay, so he has in a government he has written
NIP, yes.
NIP. So what he has received is one is BCG polio hepatitis B at birth.
Yes.
Then 6 weeks he has received the fractional IPV, PCV 1 dose, and the IP and pentavalent vaccine, WP base. Second dose, they have not received the PCV as well as fractional IPV, but they have received only pentavalent vaccine. Now it is coming to us. Now the question is, they want to shift it to ACVIP schedule?
Yes.
Totally? Okay. Yes. In that case, when you talk about PCV, he has received only one PCV dose, right? So if you give one dose at 14 weeks now, right? And then if patient goes back to the national immunization schedule and gives one more dose at 9 months, that's fine. But if he is going to stay with us, I would like to give one dose now, and after 1 month, I'll give PCV one more dose. That will take care of my 3, and then second year booster I'll be giving.
That was a clear message, sir.
But a question will be there for FIPV, IPV. There will be a problem because
many times the government vaccines, they come here for subsequent doses, So sometimes we may find difficult. This is what the scenario.
Because again, in this situation, there will be a real question for fractional IPV. Because yes, we will be giving full dose of IPV, right? Suppose if you want to give one more dose of IPV, we don't have standalone IPV available. So that will be,
Yes.
we can't go on for one more hexavalent vaccine. So then in that case, you have to either prepone your booster dose and you can give it at say 12 months, or that can be the practical way out. Else you can just send it to government again, convince them to go to government and give it 9 months.
Thank you,
The
sir.
only thing we have found out, like once the patients don't maintain that government visit, if they become defaulters, they do not give them their subsequent vaccines in the government.
Yes.
Parents said we have returned back, and then they were refused the vaccine. So this, we had a 14-week-old child shifting from NIP to IAP schedule. Now I have a 6-month-old infant brought for saying that they have heard about the flu vaccine and the flu disease in the community, and they've come for an influenza vaccination. And then they have done the primary vaccination at the NIP. As you had said, the 3 doses, but it will be only 2 of the PCV. Now they want to shift to the private sector. So how will I plan my further vaccination, and especially regarding PCV?
So the simple answer to this is convince him to go to government at 9 months. Give the flu vaccine now. After 1 month, because 6 and 7 months we give flu vaccines. You can continue with typhoid vaccine also, because 6 to 9 months you can start the vaccination. So to just make the thing simple, you should go. But if they say no, we don't want to go, then we are in the trouble, because then we have to give 1 dose of PCV. I'll give 1 more dose of PCV. That will make my 3 doses of PCV along with flu vaccine. And then again, I will have to give it 1 dose in the second year of life. That's as far as PCV is concerned.
But then, as you say, the same fractional IPV is a problem.
Yes.
Maybe prepone the first booster instead of 15 months. Prepone the booster to 1 year. 1 year.
That is the option what we can do. Or if we can go for 9 months IPV, because IPV is again problem.
Yes, sir. That's what. Standalone IPV is not available.
Yes.
Thank you, sir, for that.
Because many times we come across a patient from NIP coming to we follow the IAP schedules. So that's why we face some clinical scenario. Here again, one infant after primary immunization at NIP, government setup, comes at 9 months, sir, for vaccination. At this stage, what will you offer, sir? Whether MMR, typhoid, influenza, or what about PCV, sir?
See, this child has come to us at 9 months, right?
9 months.
So what are the vaccine which we are supposed to give at 9 months? One is MMR, flu, of course, typhoid. And now we have to look at, because it has been given a less number of doses of IPV, as well as because it is a reduced dose schedule. So of course, you can give PCV 1 more at 9 months. So that will complete our national immunization schedule. But again, the problem will be of IPV, fractional IPV. So if they are convinced, we'll give the rest of the ACVIP vaccine over here, and then we go for the vaccination. But again, if they go to the NIP, they'll be given MR now. Okay, MR, fractional IPV, and PCV. So there again we compromise. So if you want to shift it, you give it PCV. Fractional IPV, just try to give the hexavalent vaccine a bit earlier, and then that's the only way we can be the best out of those options.
The listeners, the government side, they give only MR, and we need to give 3 doses of MMR. That's our latest guidelines.
Yeah, but Dr. Jalil, what happens, like if the patient, they want to continue that NIP, so best is allow them to go to 9 months, till 9 months everything. 9 months onwards, 1 year onward, we should take over, because then we have hepatitis A, then we have MMR. At least 2 doses of MMR after 1 year of age is also enough. So I personally suggest them, now after we finish the 9 months thing, you should be with me, so that I can take care of your schedule in the best possible way under ACVIP's guidelines.
Because we encountered a lot of mumps epidemic after that. That's why we insist on the 2nd and 3rd dose. MMR.
Yes.
So there is a question in the chat box. Dr. Geeta Patel wants to know which vaccine can be given with pneumococcal vaccine and which cannot be given with pneumococcal vaccine, especially if we are planning to give a typhoid conjugated TCV or a meningococcal, is there anything that cannot be combined with a pneumococcal vaccine?
So there is PCV 13 and PPSV 23 cannot be given together. That is very clear. Then you have Prevenar and Menectra as well as Menvio. So in that particular thing, you may not be able to give Menectra, but you can give Menvio. But that also is not very stringent thing. But yes, PPSV 23 and the PCV 13 should not be given together.
So that means we don't have problem with giving PCV and typhoid, but
Yeah, of course.
PCV and MCV, that is meningococcal, you should have a thing. Maybe give the PCV and the next month going for the meningococcal.
Yeah, at least 4 weeks gap we should be keeping.
Okay. Sir, a child who had taken all the NIP vaccines till 1 year, and now at around 16 months, they come for further vaccination. Should the child receive a PCV booster? Because already this child has been given, as per the NIP, 2+1. That is
now in this particular case, there is very clear-cut recommendation that if the child has received 2+1 in government and national immunization schedule, no need to go for any more PCV dosage. Okay, for IPV you may go for the one more dose in second year and the 4 to 6 years, but because there is a reason behind it, because PCV, if you give 2+1, it is almost 100% seroconversion, and we want it till 5 years of age only. While polio, I think we need a higher concentration, and it should be a long-lasting antibody also. So we need to give them booster with the IPV, IM IPV. So I would like to give one more IM IPV in second year, and then at 4 to 6 years of age. For IPV and PCV, this particular thing, they are different. So at this stage, as far as PCV is concerned, he's been completely vaccinated. Immunization has been done. So we should not be giving any further dosages.
Yeah.
All this clinical scenario we pick up in our day-to-day practice, sir. I would like to share one more scenario. Here it is a 20 months old infant who has received all vaccines at NIP program at till 18 months. What will be your advice regarding the missing vaccines confined to PCV or HIV, sir?
So now here till 1.5 years they have received. So 15 months MR they have received. They have received DPT and polio. They have not received IPV. Okay, they must have received 2+1 IPV. So they are done. So and HIB is not part of NIP at 1.5 years. So the 15 to 18 months. Now the standalone HIB is not available. So there is no way out. For IPV, yes, as I said, I would like to err on a side giving one more dose, if available, standalone. So again, it is not available. So HIV and IPV, there is no chance of giving one more dose. So I think I would like to concentrate other vaccines. Those have been missed, and catch-up vaccination can be done.
So we will be going about with the varicella, MMR, hepatitis A, typhoid, which has been missed in the government schedule. And rightly, the president of Tamil Nadu State Chapter, Dr. Rajendran, recently in the last 2 weeks, he has given lots of public awareness by talks and also in the newspaper that there are 20 vaccine preventable disease and only 12 to 13 are being covered by the government schedule. And it is very important that the vaccines which are not covered in the government schedule, people should take it in the private sector. And so, sir, we have gone through lots of case scenarios of people switching over from NIP to us and how to go about. You made it very clear. Sir, regarding this pneumococcal vaccine immunogenicity, there is something which is the OPA titer, that is the opsonophagocytic activity, and something about the antibodies, that is the IgG. So what is this OPA titer and IgG? Are these both important? Is it one of them or is it both?
This is like, because this OPA titer is a functional antibody titer. Okay. And IgG, and that is a requirement for the licensing of any vaccine. So when you talk about IgG titer, that we have to have a correlate of protection. So you should have the immunogenicity of 0.35 microgram per ml against totally combined all serotypes. But OPA titer is a functional antibody. So when you say either OPA or IgG, no, both are important. Why? I'll give you example of it. What happened that during PCV7 was given, and we know that 6A and 19A both they are supposed to get a cross protection by 6B and 19F. Now look at a 6A. So even 6A IgM titer, whatever it was protecting 6A disease, because after PCV7 and 13, the 6A, which was PCV10 of GSK and PCV7, the 6A disease was very much under control. But at the same time, so 6B gave cross protection 6A. But for 19F, what happened? 19A went out of the hand. So I think that gives the idea that because IgG titers was good against 19A as well as 6A, but it performed better for 6A, not against 19A. So then there was a reason that OPA titers were not sufficient for that particular 19A as compared to 6A. And at the same time, the requirement for the OPA titers or the IgG titer, that was also a little less for 6A as compared to 19A. So that's the reason I think both are important, but licensure purpose, IgG titers are more important because there we have to prove the non-inferiority. But all the vaccines now, because they understand this importance of OPA titers, they have been showing all the data with OPA titers also. So they don't have to prove non-inferiority, but they just have observation whether this OPA titer are falling in line with it to the existing brands.
So, sir, you now made it so clear that both the OPA titers, which is the opsonophagocytic activity, as well as the IgG titers are both necessary to say the efficacy of a vaccine. And we know very particularly that this pneumococcus, the opsonization is necessary for the bacteria to be handled by the immune system to remove it, to win over it. And
Nandini, I'll ask one question to Chetanji because, sir, we are witnessing the world's largest rituals, religious rituals in Uttar Pradesh.
Kumbh.
So, Kumbh Mela is going on, sir. So, we are worried about the pneumococcal vaccine. Since you have talked about pneumococcal vaccine, what is the recommendation if somebody from Tamil Nadu wants to go? I remember this the Kumbh Mela last till 26, February 26. If someone wants to go to Pragyaraj, then what is your recommendation for PCV, sir?
See, as such, it is not there anywhere that there is any recommendation for PCV for Kumbh Mela. But I think what is the recommendation? There is an expert committee on PCV for the Hajj pilgrimages. There they recommend that they should be given a PCV 13 4 weeks prior to your visit. So I think we can just extrapolate that because ultimately it's the same crowd, large gathering is going to happen. Either it is a Hajj pilgrimage or it can be a Kumbh Mela. So that can be, indirectly be considered. And but as such, there is no specific recommendation.
At least how many weeks prior, sir?
4 weeks. 4 weeks.
At least you must plan 4 weeks prior to have the PCV.
Yes.
Before we are planning for that.
Correct.
Thank you, sir. This is some of the my friends ask me, sir, I am going there, whether you recommend any vaccine.
Very practical question. Very practical question.
Thank you, sir.
Sir, regarding NIP use of pneumococcal vaccine, earlier, I think just before our COVID, 2019-20, 2019 and 2020, the PCV13 was introduced in the government for high-risk neonates. Only the high-risk, the NICU kids were given. And then subsequently, the government shifted over to 10 PCV, that is the Serum Institute's pneumocil. And now slowly, recently in the last few months, the government has taken over, instead of 10 PCV, it's taken over PCV 14, which is the Newbivac from BE. Sir, there is changing thing in the government. Started with 13, and then there was a 10 PCV, and now there is a PCV 14. Sir, is there any impact of these interchange of these vaccines in the NIP? Would it make things better?
impact on the patients or impact on the pediatricians about the vaccination or brand?
Impact for the patients, I think.
Okay.
Patients, like because
Right. So,
pediatricians, we
no,
find
no, no.
definitely now most of them going to the government schedule, even though they look affordable.
Yes. So we should be knowing why this happens. Whenever new vaccine it has been introduced in national immunization schedule, usually Gavi funds it. So what they do is initially it is a Gavi funded and supported vaccine, but there is a caveat that within 5 years or certain period of time, the nation should be self-sufficient to continue the program in the nation. So what happened in India? Initially, it was Gavi funded. PCV13 was the only vaccine available. So with serotype coverage and everything, it was started. But then with advent of the introduction of this PCV10 from serum, which was very much cost effective. So we know that the country will consider as a nation what is the programmatic characteristics, what is the persistent vaccine supply, then what is the vaccine pricing or the cost, then what are the local or regional data with serotype coverage, because that also company will be showing that these are the serotypes which is common in India, our vaccine is having that. And lastly, though we don't have the much of the data, but still antimicrobial resistance to be considered. So looking at everything, government will decide which vaccine to be brought in the market, in the NIP. So yes, because PCV13 was costlier vaccine, then it went to the Serum Institute. And I think again, PCV14 must have given the data. And most importantly, supply is important. Because India being a huge country, so many doses are required. So they may not stick to one particular brand, and they may be utilizing whatever avenues available to them. And they all will be cost effective. I don't know what is the supply rate of these brands, but definitely it will be at certain specific rate for the government. And that's why these all things considering the NIP that select the particular brand. Yes, that doesn't make particular vaccine better or better of others, but that will really give a confidence to us that it has been given in the government setup, because you know that whenever we present a data of any vaccines, they will show it is in a national immunization program of 60 countries, 30 countries. So that makes the sort of confidence to that particular brand. Yes, it has been selected for the government program, but that indirectly it may help, but directly it's a different ball game, because we know that in our in private sector we want with safety, efficacy, and the cost. Cost comes last. For government, it is cost, efficacy, and safety. It's like that. So that's a different ballgame.
Thank you, sir. You made it so clear. And you had also given almost all the recent updates in the pneumococcal vaccine. We were stuck up with 13 and how the 14 has come and the 15 has come and now the 20 has come. And when initially we read about PCV20, it was only licensed above 18 years of age and for the adults. But now there is a PCV20 that can be used even for children. So that was a really very good overview. I think a very difficult subject, but you had the flow from you was so good. And let me look into any questions in the chat box, sir. I think already you answered. Which
Dr.
one is
Nandini?
better of the two, the old PCV 10 or the 10 PCV? Or the new?
Can I ask one question, Dr. Nandini?
Yeah.
You have asked about the three major brands which the government is keep on changing, all the three major brands, and you have asked for the impact. Sir, may I ask you, sir, what is the switchover or the product switching about this PCV vaccine, sir? And one more question, if all the other serotypes, say about 31 serotypes are available in one, when it will come, sir? Because the addition and deletion cost is causing too much cost factor.
So there is a thought behind it.
Any pipeline for all the serotypes?
Yeah. So first part of the question is product switching. Suppose somebody has received in primary schedule 2 doses at the government setup or other place X vaccine, and we want to shift it. SAGE recommendation say there is no, it is not allowed. You have to complete the schedule, at least primary series with the same vaccine. But if it is not available or if you don't know, then at least you don't miss the opportunity to vaccinate. You take an opportunity and vaccinate with whatever available is there. For booster dose, there are studies that PCV10 of GSK, if it has been given, and if you want to give it to switch over to PCV13, you can, because there is an incremental value to this. So that is the only thing is available. But you know that nowadays, even the National Immunization Schedule, there is so much of switching over for programmatic reason. It is fair enough, because ultimately, if you look at all these studies, there are here and there 1 or 2% here and there. If you some company will come, they will say this study, and if you say my vaccine is 10% more coverage, another person will come, they is giving the cross protection. See, ultimately, the best thing is you should vaccinate all the children of our country with PCV. So vaccination is important. Which vaccine is not important? Definitely you have to vaccinate maximum number of patients. So then ultimately, definitely we'll be going for herd immunity, and we can match the Western countries also. Now, as far as the which vaccine they are planning, now they actually they want to see that some vaccine can be produced which is not dependent upon any serotype. So serotype non-specific vaccine. So it should be working in all the serotypes. That's what we are trying to have. But as of now, we are just keep on increasing the numbers PCV 2021. But of course, till now the highest is PCV 21 and 20 and 21. So now gradually US has practically replaced the PPSU 23 with PCV 10 or 20 or 21. So maybe that will come to our Indian market soon, and then it will be a consideration.
So, sir, we all above 50 years, everybody has taken PCV 30, many of the doctors. I think once 20 or 21 comes, we'll have to take a second shot to increase the vaccine coverage.
Yes, PCV 13 or 15, if you're taken, they say recommendation is you should be going for one more.
For a 20 or 21.
Yes.
Sir, I think you had made all the points clear, and you have told us how the PCV, that is conjugate vaccine, is necessary to prime and then followed by the polysaccharide vaccine. And you also made it clear about the special, that is the high risk situations. And you must know whether it is an immunocompetent individual or an immunocompromised individual, because that is going to make a difference. Because in both, you will give PCV 13, and 8 weeks later, you will be giving PPSV 23. For a competent, it is 1 dose, whereas in an immunocompromised person, it is 2 doses, but 5 years apart. And we have to remember that PPSV 23, there is no more than 2 lifetime doses are recommended, because repeated doses of PPSV 23 will produce an immunological hyporesponsiveness, and which is going not to be useful, but is going to be detrimental. So no more than two doses of PPSV 23 in once in lifetime, with an interval of 5 years apart. So we understand from your high-risk situations how we had given PCV 13 and 8 weeks later PPSV 23. But when you went on to the updates of the vaccine and some papers, there is a time interval between PCV 13 and PP, that is your extended thing, of 1 year. Why is this difference?
It depends on an immunocompromised or immunocompetent host having immunocompromised situation. Okay. If you have immunocompromised host, because they are going to get exposed frequently, then it is a shorter interval.
Okay.
So that's the difference between this.
Okay. So, but here also in this high risk situation, immunocompetent, we still give the 8 weeks.
Yes.
But maybe that applies to adult population. Maybe.
Adult population, you can have 1 year gap, or if it is immunocompromised, 8 weeks.
8 weeks. Thank you, sir. I think
there are 2 or 3 questions in
yes,
I think in this chat box I'm seeing.
Okay, sir.
For children given, Dr. Manka is asking, children given GSK vaccine 4 doses, is PCV 13 or 14 need to be given 4 doses of? I think if they have been given on time, you need not to give 1 more dose. It will be superfluous, I think. I don't think we should be giving 1 more PCV 13 and 14 just for the sake of few serotypes more.
Okay, sir.
Then I think Dr. Vishwanathan's question has been answered by you.
Yes, sir.
And I think we go to PCV 1 year, 2 years visit.
Thank you, Chetan.
That was,
wonderful presentation.
Most of the questions answered, sir.
Yes.
Before SBS, sir, any
comment you
want to add, sir? SBS, sir.
Yeah, it will be my great pleasure to have.
That was fantastic. That is absolutely fantastic. I just wanted only two comments. One was that if in any population, if you are able to vaccinate at least 80% of children below 5, under 5, the herd immunity will be so good that you will hardly see any invasive pneumococcal disease, even one dose. That is one. Second is that you're talking about including more strains in the vaccine. Including more strains is more strenuous for the pharma industry, more strenuous for the public because of the rise in cost. And technically, to add any more antigen, 20 itself is a Himalayan experiment. To add more, it's not going to be easy. In 0.5 ml or 1 ml, technology is not there right now. Unless they improve upon the technology, you're not going to see more valency very fast. 20 is very good. Moving from here is going to be uphill. Not going to happen. And as you rightly said, pneumococcal vaccine, if it becomes 50 valent, it will cost ₹1 lakh.
And still it will be underperforming than existing.
Unless the pharma industry finds a new genetically engineered vaccine. If they find that, then it would be possible. Otherwise, it's not going to happen. And last is that there is no data of any pneumococcal vaccine switch over in terms of efficacy. So whatever we are all saying, we are only agreeing because there is no other go. But there is no data. And finally, one correction, that OPA, Dr. Nandini, does not correlate with efficacy. It's only a immunogenicity. OPA and efficacy have not been analyzed.
OPA is more of functional.
Data correlating OPA with the efficacy. OPA is considered a marker of immunogenicity rather than efficacy. Efficacy is entirely different. But if you look at efficacy data, maximum data is only with PCV13 and maybe to some extent for PCV10. All other vaccines, efficacy data is very sparse.
Okay, sir.
Very sparse. And last is the way pneumococcal vaccines are mushrooming. I don't know, already we have 2 10s, 2 13s,
2 14.
1 14. Okay, 5. I am told 2 more are going to come this year. Okay, it's going to be difficult for us to choose. But as rightly pointed out by Chetan, give pneumococcal conjugate vaccine, whatever you think is right.
So just will add one more thing. What sir has said is right. So 2+1 is a schedule. UK is the first country to try this reduced dose because they had a vaccine coverage almost 80-85%. So there was a herd immunity. So they can cut down to the dose. And now they are coming up with a 1+1. So they are giving one dose at 12 weeks and second dose 12 months. And still what they find is it is equally. Even the South African countries, Dr. Mahdi and group also, they have studied this. So if there is, suppose they compared with 2+1 versus 1+1. And South Africa, again, they have started with PCV7 and 9 around 2009, then switched over to 2013, around 11 to 12, to 10 and 13 valent. There is very robust surveillance data. So they also feel that 1+1 will be maybe sufficient, but only if you have the vaccine coverage, which is in tune of 80-85%, then herd immunity will come into picture. So that's what I wanted to add.
Interestingly, Chetan, I believe that the pneumococcal vaccine chosen by governments changes with the change of state governments.
So there is one more point, political will have to be.
So that's it. The contract changes. Okay.
That's what I said. What rate they are offering, we don't know.
We can't understand at all.
Yes.
Thank you, sir. Thank you.
Dr. Smita wants to make some comment. Dr. Smita wants to make comment.
Yeah, yes. Thank you. So if I may add to all that, Chetan, wonderful presentation.
Thank you.
Yes, and as SBS sir has said, so many more new entrants. In fact, I think this year there are 3 more 13-valent vaccines which are coming into the market, all mimics of the 13-valent which is already existing. But what is important to understand in this, gamut of the vaccines coming in, the numbers, etc., what is the licensing that we have in India? So just to add that the new entrants, including the 14-valent which we have, they are licensed. In fact, the 14-valent is only licensed currently for the first 3, that is the primary doses only. So it's very important for us, all of us practitioners who are following the ACVIP regulations, to understand what is the government licensing for each of these vaccines. I think we have to take our selection or make our selection based on this, because if you give it as apart from or outside what is currently licensed, you're using it off label in India, and you will probably be, at a position compromising yourself legally. So therefore, please keep a watch out for what is the licensing on that. And that is one thing. The third point which I wanted to raise, Chetan, in continuation of your 1+1, is that there are trials going on currently in Vietnam for a single dose. Just a single dose of the PCV vaccine that is being tried. There's a very large trial in Ho Chi Minh City, which is currently underway. Also, some parts of the UK, I think Ireland is also trying a dose. But this is, of course, as you mentioned, the 1+1, but even the 1 dose is only once there is a very, very robust vaccination coverage in the country, as SBS Sir said, 80 to 85%, then it will probably be of value. Besides which, in conditions of where there is a national disaster, or it is in very, very hard to reach places like the upper mountains of Uttarakhand, etc., where its accessibility is an issue, there probably even a dose will be what would be adequate to protect the children. So that's what I just wanted to add.
But at the same time, there is a concern because certain countries, they are giving vaccination since so many years, but there are certain serotypes which are vaccine serotypes. They are also not been under control. So there are both the sides of the coin. But yes, vaccine coverage, and that is very important. If it is more than 80-85%, the herd immunity will help. So, and I very clearly said the different recommendation as of now of DCGI approval, that PCV14 and PCV13 TT is only for first 3 doses, like primary series 6, 10, 14. Rest is not available. It is all on like off-label use. Thank you.
Over to President, sir.
Yeah, thank you, sir. And really happy that Dr. Smita Nayak and as well as Dr. Chetan Trivedi, as usual, they're presented very well and excellent deliberation also. And I thank Dr. Balasubramanian sir, the legend who has participated in our discussion. And thank you, Dr. SPS sir. And thank you, Dr. Srinivasan sir. Actually, he's as Dr. Professor Singaravelu said, he's the youngest student of our learning process. And I thank one and all and for this wonderful evening. And it's a nice presentation. And next one will be on every 2 months now. That's April second Sunday will be there. And over to Dr. Thirumurugan.
And after that, our secretary also has joined, Narmada. Thirumurugan, after your remarks, Secretary Narmada will.
Yes, sir. Thank you, sir. Thank you very much. It's an absolute pleasure, and it's mesmerizing to listen to both Dr. Smita Nayak and Dr. Chetan, 2 different ways of approach and 2 equally enlightening ways. So we are really fortunate to listen to this topic, and of course, the comments from Dr. SBS definitely added glamour to the show. So I think we can probably request our secretary to say the vote of thanks and conclude the meeting. Over to Dr. Narmada.
Good evening, everybody. Thank you all. And as usual, it was a pleasure listening to both of them with clear-cut. There was no beating around the bush. It was a clear-cut recommendations from both. And it's always a pleasure to listen to Dr. Smita Nayak ma'am, who's conducting the vaccinology course also, and Dr. Chetan Trivedi, who has been talking in various forums. Very clear-cut recommendations. I really thank both of them for joining our session. I also thank Dr. SBS sir and Srinivasan sir who have joined. And a special thanks goes to Nandini Kumaran madam on Jalil sir for organizing this program, and Dr. Tirumurugan for taking the pains to put it all in a proper forum. And Dr. Rajendran sir, thank you so much for giving us all this excellent presidential action plan. And thank you all the delegates for joining with us on this wonderful night. And hope we all meet together for the next program in the coming March. Thank you so much.
Thank you.
Thank you, Singarvel sir, again for recognizing.
Thank you, ma'am. Thank you. Good night. Good night.
Good night.
We have to thank our secretary. She has just now got down from the flight and joined.
Yes, no, sir, we were at a very important national program on release of allergy tablets for India for the first time, sir. So we had a program in the morning in Delhi, sir. Thank you.
Thank you. Good night.
Thank you, sir. Good
Thank
night.
you all for wonderful opportunity.
Thank you, sir. Thank you.
Thank you.
Thank you. Thank you, Nandini
Dr.
ma'am.
Vishwanathan, bye.
Jalil sir, thank you.
Smita Nayak.
Singaravelu sir,
Thank you all. Bye.
Thank you, Srinivasan sir.
Thank you.
Bye, sir.
Thank you.
Bye, sir. Bye.